good morning. My name is Bernard Bruyne from Aalst in Belgium. It's my privilege to chair this symposium organized by Abbott Vascular and dedicated to coronary vascular dysfunction, and more precisely, the diagnosis to be made in the catheterization laboratory. Now, when we say ischemic heart disease, we very often think actually coronary artery disease. It means stenosis at the level of the epicardial arteries, and we often forget that beyond the macro circulation, there is also the micro circulation with possibly a lot of dysfunction there. And in spite of the fact this microcirculation encompasses more than 90% of the total volume of the coronary circulation, it has remained kind of the poor cousin of the family of the coronary circulation in terms of clinical focus, research, publication. So the macro circulation is relatively simple to quantify. We just need pressure measurements and of course the angiogram. Let's not forget the angiogram. But for the microcirculation, the quintessential metric is the resistance, the microvascular resistance. And this is more difficult to obtain and to measure. So there are a couple of reasons why these microvasculature remain poorly understood. It is difficult to image. There is no good animal model. And again, as I already said, the resistance of the microcirculation is difficult to quantify. Now, if we have no measuring tool, well, then it is, of course, difficult to understand what is going on. It is difficult to have any interest. If there is no interest, there is no interest in developing new medication, and therefore no interest in developing new measuring tool. And that's a little bit the vicious circle we are confronted. And therefore, the objective of this session is to learn more about the prevalence of angina with normal coronary arteries, to learn how correctly make the diagnosis of CMD, and to learn about the importance of this diagnosis, preferably to be made in the catheterization laboratory. And to discuss these different topics, we have with us very good faculty, namely Dr. Colin from Glasgow University. We have Tommasso Gori from Mainz, and we have Alaide Chieffo from Milano. So without further ado, I would like to give the word to Colin. So Colin, the floor is yours.
Dr. De Bruyne, thank you for that introduction. Microvascular angina. These are my institutional disclosures. The objectives of this talk are to define microvascular angina, describe its prevalence, prognosis, and then finally to consider unanswered questions. Chest pain is a major public health problem. There are approximately 1 million attendances at chest pain clinics in the United Kingdom each year, with an overall cost burden for ischemic heart disease of approximately £1 billion annually. Presently, the diagnostic test in the clinic is CT coronary angiography, as per NICE guidelines. Of course, other test options may be considered. CT coronary angiography reveals coronary atherosclerosis with high sensitivity and has intermediate accuracy for blocked coronary arteries. However, in the context of unselected outpatient clinics, the prevalence of obstructive coronary artery disease is about 1 in 5 patients or fewer. The minority of those patients attending with chest pain. So what of those patients who have unobstructed coronary arteries? Well, of course, there may be a range of potential explanations, being cardiac or non-cardiac, but increasingly, small vessel disease, in other words, microvascular angina and vasospastic angina, are recognized as being prevalent problems. Indeed, the emerging evidence suggests that small vessel disease is more common than obstructive coronary disease potentially affecting 2 in 5 patients at least. This therefore potentially presents a greater cost burden to healthcare providers and greater challenges to diagnose for patients and clinicians in the absence of specific tests. And of course, angiography, as provided by CT coronary angiography, cannot specifically reveal this problem. Patients are then referred to the Cathlab, where, again, anatomical angiography is set to detect obstructive coronary disease. In this selected population, the prevalence of disease is much higher. However, angiography is insensitive for the detection of small vessel disease. And therefore, at this stage in the care pathway, adjunctive tests are indeed available in the catheter laboratory, such as a diagnostic guide wire, in this case, enabled through coronary thermodilution, which permits the measurement of microvascular resistance, index of microvascular resistance specifically, or coronary flow reserve, measured during an infusion of adenosine. The use of IMR and CFR, coupled with fractional flow reserve, therefore permits, on an individual patient basis, the diagnosis or exclusion of obstructive coronary disease, microvascular disease, when IMR is increased or CFR is depressed, and the further classification of microvascular dysfunction as being functional, where CFR is impaired, or structural, when IMR is increased. Therefore, taking the information from angiography, fractional flow reserve, FFR, and IMR, one can characterize a patient as having obstructive coronary disease and microvascular disease, that's in the top left, isolated microvascular disease only, when IMR is high, CFR is low, but FFR is normal. Isolated obstructive disease, where FFR is low, but IMR and CFR are normal. Or diffuse atherosclerosis, that's in the bottom right, where FFR is normal, but there is angiographic evidence of plaque diffusely, and IMR is high, CFR are low, indicative of microvascular dysfunction, both structural and functional. Using these techniques, we assessed during a 12-month period all elective referrals to the West of Scotland Heart and Lung Centre, which provides invasive care for a population of around 2.2 million people. Based on informed consent, we were able to assess 391 near consecutive patients undergoing coronary angiography. This work was undertaken in the context of the British Heart Foundation funded Cormica study. And we found that of those 391 patients undergoing elective angiography for the assessment of angina, 53% had obstructive disease and 47% had angina, but no obstructive disease. We further determined that when a strategy of disclosure of these test results with linked therapy, both pharmacological and rehabilitation, that this stratified medicine strategy led to improvements in angina score and quality of life, both at 6 and 12 months. But what of the prognostic implications of abnormalities in microvascular function? I would like to highlight this new work published in the Journal of the American Heart Association, led by Dr. David Bruyne in the United States. Association of isolated coronary microvascular dysfunction with mortality and major adverse cardiac events, a systematic review and meta-analysis of aggregate data. They brought together several studies in which ischemia testing had been undertaken and patients had been followed up for a number of years. They found that evidence of coronary microvascular dysfunction was associated with a near 4-fold increase in mortality. They also found an even higher prognostic disadvantage in terms of major adverse cardiac events at that time. In conclusion, microvascular angina is not a benign condition. It is highly prevalent in patients presenting with chest pain that is suspected to be due to obstructive coronary artery disease. Therefore, when specific tests are not used, microvascular angina is likely to be generally under-recognized. Indeed, this problem is probably more common than obstructive coronary disease. The use of diagnostic tests in the catheter laboratory complement invasive angiography. The diagnostic guide wire, notably using thermal dilution, permits the clinician to specifically diagnose microvascular angina and, where present, to link specific treatments to that condition. This approach is now supported by a Class 2A recommendation in the guidelines of the European Society of Cardiology. And there are indeed evidence-based therapies for this condition, notably calcium channel blockers, secondary prevention therapies, but identifying disease-modifying therapy is a current research priority.
So, Colin, thank you very much for this very nice overview. We know that you have really experience in these investigations in coronary microvascular disease. Now, which are the criteria that you use to select patients to undergo all these investigations in the catheterization laboratory? So, which is the way you select a patient for these functional coronary testing?
Bernard, thank you for that question. In the practice in my hospital, Golden Jubilee National Hospital, which is, as mentioned, a regional cardiac centre, I think our hospital is fairly representative of practice in the United Kingdom and in many centres around the world. The patient flow to our hospital is of two types. First, it is of patients presenting with angina in the community, and the clinicians believe there is a possibility of obstructive coronary disease. The patient may have already had a non-invasive diagnostic test, such as CT coronary angiography, or a functional test, although this is less the case following the results of the Scott Hart trial. So this is the main pathway of patients being referred for coronary angiography. And the use of invasive functional tests becomes mainly relevant if the angiogram has excluded obstructive coronary disease. This determination is made ad hoc. We undertake the angiogram with the expectation of finding coronary disease, and commonly we are surprised not to find that, and we are left sometimes wondering exactly what's caused the patient's symptoms. Therefore, it is important to have an adjunctive test that is accessible and straightforward to use. And that is the main circumstance that I would use a diagnostic guide wire in a daily practice. Therefore, it would be quite common for us to consider using the diagnostic guide wire during unselected patient care. The second scenario where we would use a diagnostic guide wire to measure coronary flow reserve index and microvascular resistance would be in a pre-planned referral where the patient already has a history of previous angiography, where there is a high clinical suspicion of microvascular disease. And in that situation, we would be expecting and pre-plan to use the diagnostic guide wire. But actually, I think the first scenario is much more relevant because most of the angiograms that we perform are in unselected patients where we need to be able to decide quickly, now is the time we need to use the guide wire.
Colin, what do you think is the place of non-invasive testing, like positron emission tomography, which is often considered the gold standard for flow and therefore for resistance measurements? Is that still something that you consider in these patients?
Increasingly, anatomical testing with CT coronary angiography is being performed. Indeed, in the United Kingdom, it is now the default test that clinicians would be expected to use. So I think this presents an interesting conundrum, because coronary angiography by CT is an excellent test to evaluate atherosclerosis. It is less accurate for the determination of obstructive disease, and it has very limited diagnostic value for the assessment of small vessel disease. Therefore, this calls into question the management of patients who have angina but no obstructive coronary disease. And concerningly, many of these patients will be discharged, and their care may be heterogeneous and suboptimal. So this question is being prospectively assessed in the Core CTCA study funded by the British Heart Foundation, in which 250 patients with angina but no obstructive coronary disease, in other words, no explanation on their CT scan for their chest symptoms, they are being invited to undergo a diagnostic evaluation using a guide wire, an angiogram, and acetylcholine testing in a formalized research context. So in this, we will be able to assess the prevalence of coronary microvascular angina and vasospastic angina in patients with chest pain but no obstructive coronary disease. So whilst we wait for the outcomes of that study, I think the rationale for anatomical testing per se leaves open questions in relation to how we diagnose patients with microvascular angina. And in that regard, functional testing has a key role, that being stress perfusion MRI or PET. Of course, the use of either of these techniques is determined by local factors such as their availability, such as the availability of trained staff, and also health economic factors. So I think the adoption of non-invasive tests will vary by hospital and by geography. And ultimately, if we can provide the right answer to the patient, then we can provide personalized medicine. That's the right diagnosis and the right treatment at the right time. And how we get to that situation perhaps matters slightly less. So any of these test modalities could be useful, with the caveat that if CT coronary angiography is adopted and chest symptoms are not explained by CT, then either a functional test should be performed non-invasively or potentially invasively. Thank you.
Which are future studies, Dr. Barry, that you are planning to do after Cormica trial, or which are the future direction of study in this setting that you are looking for?
Cormica involved two hospitals in the west of Scotland, 391 patients enrolled and 151 randomized. It therefore is an important pilot study, but clearly more studies are needed in different healthcare systems and countries. So on that point, I'm delighted to announce the International Cormica Study, or iCormica Study, which has been supported by Abbott Vascular and sponsored by the National Health Service and University of Glasgow. This study will run in the United Kingdom and in countries across Europe, involve 1,500 patients with angina, no obstructive coronary disease. They will be randomized to a strategy of stratified medicine with the testing involving diagnostic guide wire with IMR and CFR and linked therapies. So iCormica will be an important substantive clinical trial to provide one important part in this jigsaw as we go forward.
So this was great, and now I have a question that relates also to my case. What about the coexistence of epicardial coronary artery disease and microvascular disease? Should I only test IMR or whatever test you do for microvascular disease in patients with no epicardial coronary artery disease?
In the Carmichael study, 3/4 of patients had coronary atherosclerosis. Of course, none of these patients had obstructive coronary disease. So it is absolutely relevant to assess for microvascular dysfunction and vasospastic angina, regardless of the presence or absence of atherosclerosis. Indeed, the presence of atherosclerosis is likely to increase the likelihood of microvascular angina. The presence of obstructive coronary disease and microvascular disease is classified as type 3 microvascular angina. And that is a relevant question when considering the possibility of angina after successful PCI.
And again, following up on the question by Dr. Chieffo, what is the role of non-invasive methods such as MRI?
The role of MRI is exciting in that MRI provides information on heart structure, function, tissue characteristics, scar tissue such as post-myocardial infarction, and also importantly on blood flow. So if the provider is capable of providing information on myocardial perfusion or blood flow, this can be particularly relevant for the diagnosis to rule in or exclude microvascular angina. The microcirculation is anatomically located in the subendocardium, and therefore when there is microvascular disease, the perfusion defect in relative terms is greatest and spatially demarcated in the subendocardium. Therefore, a quantitative perfusion map produced by MRI can provide a specific signature for microvascular dysfunction in the heart.
Okay, let's move to the next presentation, which will be given by Tommaso Gori from the University of Mainz, Germany. It's actually a case report illustrating coronary microvascular dysfunction. So, Tommaso, the floor is yours.
Thank you very much. It is a honor to be here. Thank you very much, Dr. De Bruyne. Thank you very much to all the other speakers, and thank you very much to Abbott that invited us and made it possible. So the title of my case, or two case reports, is a little bit unconventional, but the answer is relatively clear in my mind, and I will give it at the end. So I'm talking about angina without angiographic obstruction. The first of the two patients that I'm presenting is a female, 67 years old. She has a history of two-vessel coronary artery disease in the Alaide and the right coronary artery. She has a normal systolic function. She has no valve defect. She has the traditional cardiovascular risk factors, including passive smoking as a waiter in a restaurant, and she suffers of depression. This is kind of a typical feature of this type of patients that maybe come multiple times to the Cathlab or to the emergency room with angina. She came in this case this month, actually in May, and she was admitted to our chest pain unit for dyspnea of NIA stage 2 and palpitations. She also had some kind of angina, but it wasn't really a typical stable or unstable angina. On ECG, there was a ventricular bigeminus. There was diffuse 1 millimeter, so again, not really major, but there. ST segment depression. There wasn't really focal. There wasn't really referable to one particular wall of the myocardium. Her troponin was, however, high, with a normal value of 24, so it was 6 times higher than it should have been. First, we ran out the hypothesis of lung embolism, and that was cleared out with a CT scan. So she had no lung embolism. Her myocardial function was good at angiography. The right coronary was also good. Actually, she had a history of a coronary artery disease of the right coronary, but the right coronary artery was actually the best one. The circumflex coronary was also fine, a relatively large vessel. The colleague that did the angiogram suspected that there could be something at the ostium of the circumflex, and therefore he did an OCT, which was, however, negative. So it only showed some calcium at the level of the ostium of the circumflex. You will see it better in the next slide. So there was some circumferential calcium, but no real stenosis. The Alaide was the most diseased vessel. So here, first of all, on the top, you see that there was some kind of inside of a stenosis of the ostium R6, which we could rule out with OCT. The Alaide showed an intermediate stenosis in the proximal to mid third, relatively long, and therefore the colleague decided to do an FFR to see whether this stenosis was hemodynamically relevant. It was indeed not formally hemodynamically relevant. The FFR, the final FFR was 0.82, even though there was a step up in the pressure or in gradient exactly at the level of the stenosis. Because the colleague wanted to make a complete assessment with imaging and function of the vessel, he also studied the microvascular function, and he measured the CFR and IMR. So this patient had a CFR of 1.9, which is pathological, and was caused by two different defects. One was the FFR, so the epicardial stenosis, also almost pathological. The other one was the pathological IMR. This is the index of microvascular resistances, and it expresses the capacity of the small blood vessels to decrease their tone in response to adenosine in this case. So 26 is the official value that is pathological, and in this case it was 26 exactly. So in order to be more complete, we actually also did an MRI at rest showing a diffuse area of enhancement in the subendocardium, circumferential as well, and in response to adenosine. Now, I'm not an expert of MRI, but this is what the colleagues told me. There was no late gadolinium enhancement, so there was no scar. The T1 relaxation time was mildly elevated, suggested some degree of fibrosis or edema, but what was more evident was an area of subendocardial enhancement, suggesting or confirming the evidence of microvascular dysfunction that was diffuse and across all segments in the subendocardium. Now, 26 is not really amazing, but this patient really had a mixed epicardial and microvascular coronary artery disease. So it's not the end, it is the beginning for this patient. What do we have for therapy, as Dr. De Bruyne said, is maybe not really satisfying. We do give aspirin, we do give lipid lowering drugs. We do treat the depression, which is typical for a patient with so complex disease. And then we try with ranolazine to fix up the metabolism of the myocardium. Again, 26 is maybe not very high, but let's see the second patient. This is a male of 61 years old. He had a stenosis that was treated with a drug-eluting stent in 2017 for an intermediate evidence of stenosis. He had typical cardiovascular risk factors, including diabetes, and he was admitted, which is the most important thing, 5 times in our chest pain unit within very few months, always for unstable angina. He underwent all the time angiograms, which showed no lesion. Now, just to show you very briefly, he really had no stenosis on the angiogram. You may see the videos or just believe me on my words. There was no evidence of an epicardial stenosis. We ran IMR also in this patient, and this patient had an IMR of 63, so almost 3 times as high as the upper limit of normal. This patient was a clear microvascular disease patient, and that was the reason why I underwent 5 times useless angiograms, probably. So because Wiseman has more questions than conclusions, my only conclusion is that this is the beginning, for sure. Even though we accept the existence of microvascular resistance since many years, this is the beginning of solving this problem. And I have many questions to my co-speakers. Thank you very much. So my first question, and I'm here really to learn, is about the clinical presentation of those patients. Both patients that I presented did not have typical stable angina in terms of exercise chest pain. Most of the patients I see with microvascular disease actually have very variable symptoms. One day they can go skiing, like my second patient, and one day they have CCS4 angina. Is this also your experience?
Okay, thank you, Tommaso. It is indeed a little bit my experience, even though I also have to confess that my experience in this field is very limited. As you stressed yourself, we are at the verge of a new area, and there are a lot of things to discover and to explore, including the symptoms of these patients. And what is striking is that there are a lot of acronyms around. MINOCA, INOCA, ANOCA. Only this tells you a lot about the uncertainties about what is underneath. Not even angina or ischemia is absolutely certain. So it is not surprising for me that these patients have very variable symptoms. It is very often completely different than patients with a very tight stenosis in the proximal Alaide and classical exercise-induced ischemia. But again, I cannot tell you how it is normally. I simply can add that we have to learn a lot, including about the symptoms. Now, I fully agree also that if we try to organize clinics of patients with symptoms of chest pain and normal coronary artery disease, it will be key to select these patients very properly. And we will discuss that later on. I'm sure Dr. Chieffo will allude to this, but there are some classifications and some criteria that has to be kept in the back of our mind to select these patients. It's not all the patients that we have to send with completely atypical chest pain and normal coronary arteries that we have to send for these kind of further investigation.
So the next question is also a methodological one. I was almost ashamed of presenting a case with an IMR of 26, which is really almost normal. But then the MRI convinced me that 26 is actually maybe not really normal. What about your practice? Is 26 a pathological value? In my own opinion, I actually believe that 8 or 10 or 15 is normal. What do you think about it?
So it was just accepted for publication in European Heart Journal, the expert consensus document that I co-chaired with the APCI together with the group of microcirculation and the Covadis group, and actually they give as point the 25. Then clearly this is theory, and then in clinical practice I do agree that is not the value itself has to be so categorical, but you have also to take into account the other examination, as you did, for example, with your MRI. So I think that we have to use these tools. These are very important for our diagnosis, because finally we can be able to do a diagnosis to this patient, but it has to be integrated with the clinical history of the patient and also other examination that we do, and in your case, MRI.
So, Tommaso, you probably have quite a large experience of these thermodilution measurements, and I insist these are bolus thermodilution measurements. We will maybe allude later during this symposium on continuous thermodilution, which is different. But with bolus thermodilution, you take a little bit of saline, in the syringe, and then you inject it, and you do it 3 times after each other. In my experience, is that there is quite some variability, and this is even foreseen in the Coexistence device, which allows you to eliminate and replace one of these values. Is that also something that you are used to do, or do you simply take it 3 times and then look what the value is, the average value, whatever the variability of these measurements?
No, I do correct the outliers. Of course, there is it's like in research, you always feel bad by removing the outliers. So it's always hard on the Cathlab there when the patient is there to decide which values are really not making sense. So tendentially, I use the same approach as when looking at data from a study or anything, or in the clinical practice. If something is really out of the other values, or of the mean of the other values, then I try and repeat it. Of course, we should not a priori discard something just to get a result that we're pleased of. So tendentially keep everything and try to understand it. That was one of the golden rules of Morton Kern. Just accept the data you get and try to understand them before moving forward. But of course, sometimes you do have wrong data. It's very important to, in my practice, it's very important to streamline those measurements, because at the end of everything, they're not really too complicated to do. And when you do them right, then you have very standard results, or stable results.
Yeah, well, thank you, Tommaso. The next speaker will be Dr. Chieffo, Alaide Chieffo, who is well known as a, let's say, hardcore interventional cardiologist at Milano. And I think it is very telling to have someone like you being involved and interested in microvascular disease, because you are actually proving, or at least telling us that, hey guys, we have to look to something else than just the epicardial vessels. The microcirculation is very important. And I think that someone like you being interested in this microcirculation is already an important piece of information. So Alaide, the floor is yours.
Thanks, Dr. De Bruyne, for your introduction. I mean, my interest in the topic came from my everyday practice. I mean, not to have the possibility to give our patient the right diagnosis make me more interested in this field, and trying to find a solution to make a right diagnosis and a right tailored therapy for the patient. In these slides are shown my conflict of interest. So the case today is a 60-year-old female. She has traditional cardiovascular risk factors. She's overweight. She has dyslipidemia. She's in menopause since 10 years. She came to my attention because of effort angina with CCS3, with limitation to her everyday activities. She's a housewife, so she was limited in her routine working in the house. She was tested by a referral cardiologist with a stress test, and there was a reversible ischemic defect at the stress test. Lab testing, total cholesterol 225, LDL 140 milligram. And clearly there was still some space for optimization of her medical therapy. Therapy at the admission was carvedilol 625 2 times a day. And this is her coronary angiography. So she was referred to me, and clearly with angina and positive stress test, there was an indication for coronary angiography. And as you can see, the coronary angiography does not show any obstructive coronary artery disease. So we are in front of what we would state as an INOCA. So she has ischemia by stress tests and symptoms, but at the angiography, apparently this is normal. So maybe some years ago, we would just label this normal, think that the patient is overweight and she's 60 and maybe she has some psychological disorders, or maybe she would have been treated with something less like anxiolytic. But nowadays, I think we have evidence from studies, and we do have tools that we can use in our Cathlab to make a right diagnosis. This is taken from an expert consensus document that I had the honor to co-chair with Dr. Kunadian on behalf of EAPCI, and together with different groups that are working since years in this field, like the COVADIS and the microcirculatory groups. And honestly, I have learned a lot from this experience because, as it was said at the beginning, I'm interventional cardiologist. I mean, I like also to be a cardiologist, but as I said before, I mean, some years ago, I would label this patient, she has nothing, and go to next. Now, with all the literature coming, and honestly also with this document, I learned a lot. And actually, I learned that you can have this entity as called as INOCA, and you can have some characteristics of this patient. Clearly, you have to distinguish between vasospastic angina or coronary microvascular dysfunction. And there are some characteristics of the patient that can fit one of the two different syndromes, and for example, the presence of overweight or other cardiovascular risk factors. And this is the diagnostic workup that we came in our expert consensus document. What to do? Clearly, you have to evaluate the patient. First, you are talking about patients that are symptomatic for angina or equivalent, and patients that also had non-invasive testing. In this case, she did stress test. Then next step is to go, as in this case, with invasive evaluation. First, to do invasive coronary angiography, then to do FCA guide wire and adenosine test, and then to test as a step 3 FCA vasoreactivity in order to make finally a diagnosis: epicardial vasospastic angina or microvascular angina, or the presence of mixed components, so microvascular and epicardial vasospastic angina. And so in this case, you are able to identify INOCA endotypes, and according to the INOCA endotype, you can manage the therapy of this patient that we can discuss later on. And as we were saying in the prior presentation, what we are going to evaluate is diagnostic first, clearly the coronary angiogram, if there is no disease or if there is something intermediate, first thing you do is FFR. There are some tools as Coexistence that give you the possibility to do it all. So you can do FFR, you can do CFR, you can do IMR, and according to the parameters and the different parameters, you can come up with a diagnosis. Or if you are not, you can have in some Cathlabs and in some experience and in some countries, you can add on top of vasoreactivity testing with the acetylcholine. We have to say that this is acetylcholine test, not so widely available in all the countries. So in most of the case, actually, you can just rely on the other kind of testing with adenosine testing. You don't have to go to that, or in the countries where you have available, you can finish all your diagnostic workup also with acetylcholine test. And again, the bottom line is to try to identify INOCA endotype, because according to the endotype, there is a different therapy that you can give to this patient. And this is what we did in this patient. First, we did an FFR that was negative, 0.93. We did with thermodilution, with the Coromantis system, the measurement of IMR and CFR. So in this case, CFR was 2.0, which we can claim again, which is the right threshold. We are a little bit in the gray zone, but we would call this abnormal because there is not normal vasodilatation in this patient, and then IMR in this case is 13. In this case, we didn't stop here because we can discuss CFR value if it was abnormal. It is most probably, but in order, because in my lab I have it available, and because I have also to say in our hospital as a full professor since last year was Professor Camici, that was one of the pioneers of this kind of disease, and we learn a lot also from his studies. We finish our diagnostic with also acetylcholine test. And so you have parallel on the two panels. On my left, there is the coronary angiogram baseline, and then on your right, you have the different steps of acetylcholine, step 1, step 2, and step 3. Clearly, if you have vasospasm in step 1, you don't have to go further to step 2 and 3. But in this case, it was a first step, anything was normal. There was a second step of acetylcholine, and again, we could not see any spasm in the epicardial, and also acetylcholine 3, nothing. But if there was not any epicardial spasm, there was indeed the development in this patient of chest pain and EKG changes. Then maybe you can see now it is quite small, but there was an important ST depression at the EKG. So we don't have epicardial spasm, but we do have a CFR of 2.0, and we have with acetylcholine chest pain that is the same chest pain that this patient is having in her everyday activities, and there is ST depression at EKG. So we are going, which is the INOCA endotype that we can apply into this patient. This is taken from the Cormica trial, from the appendix of Dr. Ford and Dr. Berry publication. That was, I have to say, something very important in the field, and really clarified what we have to do and also how we have to tailor the therapy. So this patient would fit exactly in microvascular angina and microvascular spasm. So we don't have vasospastic angina, but we do have a microvascular spasm with this CFR of 2.0, and especially after acetylcholine, the presence of ST depression EKG and presence of chest pain into the patient. This can be quite rare, but this was actually the diagnosis we were able to do to our patient. And so what to do now? We have our endotype of INOCA that is identified by our algorithm. And the first thing we have to propose to the patient is lifestyle factor changes, nutrition, exercise, weight management. Just to remind you, this patient is overweight, smoking cessation, and also able to keep into attention the stress, because it's an important factor. Then risk factor management, as we have seen, the patient has dyslipidemia, and honestly her lipid profile are not under control, so we have still space to manage this. And in case you have diabetes and hypertension, also you have to work into optimizing their therapy, and then going specifically in anti-anginal medication. So in this case, we identify the endotype of microvascular angina with microvascular spasm. So first line are beta blockers, but the patient was already on carvedilol and it was ineffective. Second line is calcium channel blocker. Then you can go with nicorandil, ranolazine, ivabradine, and trimetazine. And you have to consider, as I was saying, on top of that, statins. That is the case because she has also not controlled dyslipidemia and ACE inhibitors. Indeed, and this is not the case if the patient has also vasospastic angina, first line is calcium channel blocker, then long-acting nitrates and nicorandil. And this is what is the suggestion from the expert consensus that I was talking before. So in this specific case, again, the NOCA endotype was identified. We recommended the patient a change in lifestyle factors, to be on diet and nutrition control, to control the risk factors, dyslipidemia, and we added atorvastatin 20 milligrams. And then, since the patient came to our attention because she was in beta blockers, carvedilol, and it was ineffective, we started diltiazem 120 milligrams twice a day. We have also the follow-up of this patient. The patient, after we changed her therapy, and this is a 6-month follow-up, is asymptomatic for angina and or dyspnea, so she's able to do her homework without having chest pain, and she repeated the stress test, and this is negative. So I think that in this case, with all the tools that were available and were used, we were able to identify NOCA endotype, and we were able to give a tailored therapy to the patient that actually worked out.
Okay, so thank you very much, Alaide, for this very nice demonstration, very, let's say, crystal clear demonstration of a microvascular spasm. And you also added, well, probably it's not that frequent. It is probably not that frequent, but it's massively underdiagnosed. And your demonstration was really very, very nice. Now, I have one question. You mentioned that you have led these consensus document that might be published soon. Could you summarize, let's say in a nutshell, which are the big lines of the treatment options that we have in these patients? Is that possible, or do you have a slide at hand that we can show again?
Yes, I mean, I think the slides that I show you regarding the different treatment, I mean, maybe we can then add while we are speaking. So the whole point is that it's not only the medical, so this is the slides, and then maybe we can go into details of that. So the first important point is, again, lifestyle factors, because like a continuum of all these patients, most of the time they are overweight, they have a bad nutrition, they do not exercise. So these are things that we have to stress together with our referral cardiologist, or if the patient is referred to us. These are important factors, sometimes not taken into consideration, especially from us as interventional cardiologists that see the patient only in the Cathlab. But that's a very important point. Also, the second important point, again, as general cardiologist, is the risk factor management, because, for example, in that patient, she has a clear dyslipidemia, but she's not in statin, which is something quite unusual, that you have a statin naive patient. Most probably the cardiologist thought that it was a false positive of the stress test, I don't know, but that's important because we had to put the patient in statin that she was not before. So that's important, like the control of hypertension and diabetes. And then at the end is drugs. So when you are able to identify the NOCA endotype, and in this case you have a microvascular angina, so first line is beta blockers. Beta blocker like nebivolol, that you can go from 2.5 to 10 milligram daily. But as in this case, actually the patient was on carvedilol and it was not effective. So we have to shift to calcium channel blockers. And in this case, actually, we went to calcium antagonist In the recommendation, they talk also about amlodipine 10 milligrams daily, but you can go also with diltiazem or verapamil. And then ranolazine is also indicated as a third line, trimetazine, and in common also with vasospastic angina, you have to consider ACE inhibitors and ARB. ACE inhibitors like Ramipril 2.5. Indeed, it was not in this case, but if you have identified vasospastic angina, the drugs of choice is for sure calcium channel blockers, and again, amlodipine 10, or, and this is our preference in our hospital, verapamil 24 milligrams or diltiazem as 90 milligrams twice daily, or 120 or 360. I mean, you don't have to be afraid to go with up and higher dosage, because some patients, especially men or overweight, they really need full dosage of calcium antagonists in order not to have any more angina. And then you can add long-acting nitrates and nicorandil as third choice.
Dr. Chieffo, most clinicians do not have access to acetylcholine. In your patient, the coronary flow reserve was 2.0. Usually, we do not have acetylcholine available in the Cathlab. Therefore, how would you diagnose this patient based on history and clinical need? My suggestion is that the results could be viewed as abnormal based on impaired vasodilatation, but I would be interested to learn your view.
Okay, so thanks, Dr. Berry, for the question. I agree. I mean, we could claim that a CFR of 2.0 is not perfectly normal. It can be abnormal, despite sometimes the cutoff that are made in the documents, also in our document. So in this specific case, with the patient having chest pain, having a positive stress test and CFR of 2.0, we can consider also this result as abnormal. So in case Cathlab do not available acetylcholine, we can also make a diagnosis starting from the value that we got. Having said that, if on top of that you have also the possibility to do acetylcholine, as we have in our lab, you can have a clear view and a clear diagnosis.
So thank you very much, Alaide, for this very clear presentation again. Now, I think it is time to wrap up and to try to distillate the key learning points. And I identified 5 of them. And the first is very simple. CMD, coronary microvascular dysfunction, is real. It is not just an elucubration by cardiologists not satisfied with the diagnosis of epicardial disease, which is not always found. No, it is really an entity which exists. It is probably the most important origin of chest pain in patients with angiographically normal coronary arteries, what is called the ANOCA syndrome. So it is real, that's for sure. The second is that there are major clinical implications. There is a recent meta-analysis published in the Journal of the American Heart Association, emphasizing the 5-fold hazard ratio for mortality and MACE respectively. I'm not sure this is really 5 or 4-fold increase. Maybe this is a little bit exaggerated, but definitely there is a prognostic implication of the diagnosis of coronary microvascular dysfunction. The third key learning point is, at least for me, that let's say there is a kind of effort of standardizing the clinical criteria. I will not go through this slide, which is too busy. I would encourage you to go to this reference. This has been published in many journals, more or less the same table is available, but it is important to select the right patients to have to undergo these coronary functional testing that we described during the previous presentations. The fourth thing, which is really important, and this is recent, is that the microvascular resistance can now be quantified. And I would like to discuss with you two approaches. We have alluded already to IMR, the index of microvascular resistance. Again, it is an index and it is obtained by bolus thermodilution. You have seen already examples, and probably many of you have already experience with that. But this is only an index of resistance. This is not an absolute value. Now, the new kid on the block, so to speak, the new, let's say, possibility that we now have in the Cathlab and is available already on Coexistence is no longer to distillate an index, but really to measure absolute flow and therefore absolute microvascular resistance. We are not going to the details, but this is how it looks like. It is actually very simple. Instead of injecting a bolus, we infuse during a couple of seconds saline at a continuous rate, and the computer will provide you immediately what is the microvascular resistance. And if you have the microvascular resistance, you can assume that you can calculate microvascular resistance reserve, which will be probably in the future the equivalent for the microcirculation of what fractional flow reserve has been for the epicardial circulation. And finally, the fifth point, it is no longer justified to say, well, why to bother and to measure all these things and to make it complicated? Anyhow, there is no treatment in a shrug of shoulders. This is no longer true. We can identify, and Alaide insisted very well on this, we can identify endotypes, in other words, subtypes of these syndromes, of these in these patients with chest pain, suspicious angina, but normal epicardial arteries. I will not repeat, of course, what she already explained, but I would just like to insist on the physical revalidation of many of these patients. I strongly believe that this is the basis of any of these, of the treatment of any of these endotypes. And I think we should pay much more attention to that. There is not only the 90% stenosis in the epicardial vessel. So to wrap up, I think we are at the dawn of a new era. Maybe this is a little bit too bombastic, but at least we have to realize as interventional and invasive cardiologists that microvascular disease exists, is actionable, and that the diagnosis, and this is our task, and that the diagnosis should be made in the catheterization laboratory. We now have the tools to perform that. Thank you very much, and thank you for your interest and attention. Bye-bye.